Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Alhamdulillah for this really fantastic meeting. Really, I think everything has been said before about the importance of including everybody in clinical conferences. Some of the conferences tend to be relatively exclusive, and I think this is the not exclusive conference where everybody can share their practice and their guidelines. So it's a great pleasure to be sharing the first session of the first day. I'd like first of all to introduce my co-chair, Dr. Iman Azmat, who's a consultant non-invasive cardiologist with a lot of experience in cardiac imaging, in particular cardiac CT and echo, and also a dear friend and colleague. Today, our first session is going to be primarily about arrhythmias, and no session about arrhythmia would be complete in this country without Mu'taz al-Qadri. So I have to say that I've known Mu'taz for years now. We worked shoulder to shoulder in SKMC. We're now neighbors in Mediclinic. So it's a small world, and really I think he gives us a lot of experience, both clinical, as a clinician, he's a phenomenal clinician, as an electrophysiologist, there's nobody better, and also as a very, very, very brilliant lecturer delivering really important topics which are somewhat complex. He's really brilliant in that regard. So we're going to talk today, he's going to give us a really nice overview of catheter ablation, which patient to be referred, and what outcomes to expect. And I expect a really phenomenal talk, as usual, from Mu'taz.
Assalamu alaikum. Good afternoon, everybody. Thank you, Hani, for this nice introduction. I don't deserve half of it, to be honest, but I appreciate the kind words. Right. So EP has been around for many years. We're going to be talking predominantly about what kind of patients you need to refer to us, what to expect, and what you need to tell the patients when you're referring them for various disorders or various arrhythmias, and what they should expect in terms of success rates and possible complications. Can I have my slides back? Just a second until we have the slides back. Right. Okay, so it's not moving the slides. We get somebody to help. Oh, there you go. It's not moving. Huh? I am pressing the green button. Yeah, I am pressing that green button. Khalas, the conference has ended. It's not moving the slides. Slides aren't moving in the back. You need to change the battery on this or something. I mean, I don't know. Exactly. It's a proper complete heart block. There's nothing going on there. Okay, that's better. Right, so electrophysiology started initially as a diagnostic specialty, and this was a great start of any specialty because we spent about 20 years just understanding the electrical signals in the heart without actually doing any ablation. So most of the ablations that we do now really goes back to the understanding that we had in the first 20 years or so of electrophysiology. Radio frequency then developed in the mid-1980s, and this allowed us to deliver energy, to deliver ablation in a more controlled fashion. 3D mapping started to get developed in the early 2000s, and around 2010 we started having cryotherapy as another modality for delivering energy to do ablation. The latest kid in the block is something called pulsed field ablation, which uses a principle called electroporation, to deliver energy or to deliver ablation to the cells without what's called non-thermal energy. So it's not dependent on heat or freezing. The procedures, and a lot of the times, are considered to be curative, and even if they don't cure the patient, they tend to reduce the symptoms and the reliance on medications in these patients. In general, these procedures have very low complication rates compared to other procedures in cardiology, and they tend to have a very short hospital stay. And the success rates have been gradually improving over the last 20 to 30 years, and the complication rates have been going down as well. So when we do an EP study, we start by the basic EP study. We park our catheters in various chambers inside the heart. So we have a catheter sitting in the right atrium, catheters sitting near the His bundle, catheters in the right ventricle, and catheters around the CS. So what do we do during an EP study? The first thing we do is we take some basic measurements. So we measure how long it takes for the electricity to move from the sinus node to the AV node, how long it takes to go from the AV node through the His bundle to the ventricle, and so on. Then one of the most important things we do is that we actually stimulate the heart to have the arrhythmia. And a lot of the times we cannot do ablation unless we can induce the arrhythmia. So we do something called program stimulation. We give extra beats at certain times to be able to induce the arrhythmia, whether it's SVT or a flutter or whatever. If we induce the tachycardia, it's not just to have just fast heart rate. We need to confirm the diagnosis. So SVT could be atrial tach, could be AVNRT, could be AVRT. So we do some pacing maneuvers on it to confirm the diagnosis and make sure that we're dealing with the right thing. After that, we use an ablation catheter to deliver the ablation energy, whether that will be freezing or burning or radio or pulse field ablation. And then after that, we spend about half an hour at the end just repeating the testing and making sure that we can't induce the arrhythmia again. So if at the beginning we were able to induce it, let's say with 2 beats at 200 milliseconds and 300 milliseconds, reliably 3-4 times we were able to do that, and then I do the ablation, at the end I should not be able to induce any arrhythmia with the same sequence. So common ablation procedures that we do, I've picked up really the main ones. So we have SVT ablations, and for my practice, it's about 50% of what I do normally. And this falls into AVNRT ablation, AVRT ablation, and atrial tachycardia ablation. We have the typical atrial flutter. We have the atrial fibrillation ablation, and then we have the PVC and VT ablation. And that probably encompasses roughly about 90-95% of what we do in terms of ablation work. So for SVT ablation, this is a classical ECG of a straightforward SVT. I'm sure you've seen quite a lot of them. And for us, we like to distinguish between the SVTs that are relying on the AV node, so like AVNRT or AVRT, where the His bundle is part of the circuit, and things which are not relying on the AV node, like an atrial tachycardia, which is just a focus firing rapidly in the atrium. So if we're looking at the ones which terminate with vagal maneuvers and adenosine, in general, we're talking about AVNRT and AVRT there. So that's why it's important when I see patients or physicians referring doctors to me, that piece of information is very useful. So if you tell me we were able to terminate it with vagal maneuvers, that's a very, very useful thing for me. I know I'm probably dealing with either AVNRT or AVRT and not atrial tachycardia, for example. What's the indications for SVT ablation? Now, we have become very aggressive with treating SVT with ablation. And anybody who gets more than one episode of SVT, that they had to go to hospital or deal with it, or it's becoming recurrent, they have a class 1 indication for ablation in this category. This specific category of patients with WPW, in addition to treating the SVT itself, there's also a role there in assessing the risk of sudden death in patients with WPW, because patients with WPW have roughly about 1% or 1.5% risk of dying suddenly because of the accessory pathway throughout their life if they develop pre-excited atrial fibrillation. So part of our assessment to these patients is to actually pace the atrium faster until we see at what level the pathway will stop conducting. And if it stops conducting at less than 250 beats per minute, well, it's a safe pathway. I'm not too worried about it. But if it can conduct up to 300 beats per minute, potentially it could be dangerous, and normally we would advise ablation in this case. So this is an example of AVNRT, what we do with the circuit. So as you can see here, you can see the laser. This is what we call the His bundle, and they've got the left bundle, the right bundle, and the His bundle, or the AV node, has 2 inputs into it. We predominantly use something called the fast pathway. Well, that's what most of us would use. But about 1/3 of the people have an extra input into the AV node called the slow pathway. And the majority of people never use that. It doesn't cause any problems. The electricity goes much slower in the slow pathway and much faster than the fast pathway. So in normal circumstances, we always use the fast pathway. But when you develop AV and RT, what happens is that the electricity goes down the slow pathway, goes up the fast pathway, and then comes again down the slow pathway. So you develop this circuit where the electricity is just running very rapidly during that. So what do? What we need to do is to disrupt this. We need to disrupt this connection of the slow pathway to that area. So we go in with our catheter from the IVC, do some ablation points just at the anterior lip of the coronary sinus, and that will stop the input of going into the node. So we just disturb it. We don't necessarily need to completely ablate the slow pathway. It's enough for us just to destroy the connection with the fast pathway, and that will be enough for us to stop the SVT from happening again. If we move to WPW, or accessory pathways, so these are bypass tracks that connect directly the atrium to the ventricle. And this is a slide from the data from the West. So in the West, 85% of the pathways are in easy locations. So about 60% of them are left lateral, and these are easy to get to normally. 25% or so are from the posteroseptal area. Again, they're nice and easy to get to. Then you get the really difficult ones, like the ones which are near the his, the anteroseptal, the parahiscian, and then you got the ones which are difficult to locate or to stabilize the catheter, which are the right lateral ones. In the Middle East here, we have a different distribution. About 50% of our pathways are actually in these locations, and only about the other 50% comes from the easy locations. So somehow we tend to have more difficult locations in our population, and that's probably because we collect them from all around the world. So we get a lot more, parahiscian pathways. I've never done as many right lateral accessory pathways as this country. So this is an example where we're doing a 3D map. So we pace from one chamber and we see where the electricity emerges from the other chamber. So if you pace from the V, you can see it's emerging here into the atrium. And this is the location where the pathway is connecting. So we just go into that area and we ablate in that area and get rid of it. So what success rates do we expect? So we expect really success rates above 95%. It's not 100%, it's almost 100%. There will always be some patients who would have recurrences that, the area would recover again, the heart may repair it again, or that it's coming from a deep area. But these are very, very good odds in medicine. The complication rate is really low. We worry predominantly about the risk of AV block in these patients with SVT. Risk of tamponade or damage to the coronary arteries in general is very rare. It's probably less than 1 in 1,000. So in general, if you have somebody who has recurrent SVTs, it's very important to recommend. I've ablated a lady who's had SVTs for 45 years, and she's been getting them every week. And finally, she agreed to have the ablation. And now I've seen her yesterday. A month after that, she said, "Oh, now my life has begun." And I said, we've been talking to her for years about it. Patients are very anxious about these procedures. So atrial tachycardia is another type of SVT, but it's due to a rapid focus, automatic focus, firing very rapidly. So we have to go in the atrium, hunting around, finding the area where it's originating from. So the indication is recurrent atrial tachycardia despite medical treatment. The commonest sites where these originate from, the commonest site is the crista terminalis, which is where the thick part of the right atrium with the smooth part of the right atrium join itself, on the lateral wall of it, followed by the coronary sinus ostium, then the pulmonary veins on the left atrium, and then the tricuspid valve annulus. So they are fairly common places where these arrhythmias originate from. So this is a case that I did a few years back. So we go in with our 3D mapping catheters. We make a geometry of the inside of the left atrium, and while we're doing that, we're collecting points. We want the earliest point. That will be the origin where it's all coming from. And you can see the computer will gradually annotate, and you can see it's coming from this area there. So we've annotated that area. So then what we do is that we start doing the ablation. You can see here, once we start going the ablation, it will just slow down now. So it just slowed down there. So within 2 seconds, we managed to ablate it. Now that's good, but we want to give some extra lesions just to make sure it doesn't come back. So after finishing this, we do about 5-6 lesions around that area so that hopefully it would never come back again. So what do we expect in terms of success rate for atrial tachycardia? So it's 80 to 85%. Now the reason being is because we need the atrial tachycardia to be sustained on the day. I sometimes hate atrial tachycardias because you go on the day, you bring the patient, you try all the tricks in the book, and you can't induce the fast heart rate, and therefore you can't see it. It's like a lighthouse in the sea, but the light is out. So the ships can go past it, and they would never be able to tell where the port is. So sometimes we are dependent on the arrhythmia happening there. Complications are again very, very low. Tamponade, phrenic nerve injury if you're very close to where the phrenic nerve passes near the right atrium. AV block if it's very close to the AV node, but these are relatively rare. The next one would be typical flutter. So typical flutter, this is a typical flutter ECG, sawtooth appearance, positive P wave in V1. So what we call typical flutter is where the circuit goes around the tricuspid valve annulus. And the really typical flutter is where it goes counterclockwise around the tricuspid valve annulus. There's another typical flutter which goes clockwise, it uses the same circuit, it's done with the same ablation. Both of them are called typical flutter. I normally offer it to people who have more than once developed atrial flutter. It can be done while the patient is in sinus rhythm, while they're in flutter. If the patient has had previous cardiac surgery or has had previous atrial ablations, like atrial fibrillation ablation or something, it's less likely that it's going to be, typical atrial flutter dependent on the CTI. It's probably related to the scars from the previous ablations. It often overlaps with the patient. This is a very important point to feed to your patients. So patients get an AF flutter ablation. 3 years down the line, they develop AF. They say, doctor, you did this AF ablation, a flutter ablation, now I have AF because of that. They're not related to each other. It's just they coexist in the same type of patient. So you dealt with the flutter, now the fibrillation will show its face later on. We ablate the flutter on the right side. The fibrillation is predominantly a left atrial ablation. I don't even enter that chamber. So it's not us causing the atrial fibrillation in these patients. So this is a map of an atrial flutter. You can see this is a clockwise flutter. It goes around in a clockwise fashion. So what we do is that we do a line from the tricuspid valve to the IVC. And you can see here now when we're pacing from the CS that the electrical signal does not cross of this line of dots there, which is the ablation points that we've done. So that's why we block that line. We break that circuit. So what success rates do we get with flutter ablation? 95% again. There's a 30% chance of patients developing atrial fibrillation. If I see somebody who has evidence of atrial fibrillation, I often do flutter and fib ablation at the same time. Doing the flutter ablation on its own, fib almost certainly will show its face later on. Complications are very rare with flutter ablation. I'm happy to do it to patients up to the age of 90, to be honest. Rare complications like MI or AV block because you're ablating near the right coronary artery. Then we move to AF ablation. So the indication is persistent paroxysmal atrial fibrillation despite medical therapy. But with the latest update to the guidelines, it's even becoming a first-line therapy. So if patients don't want to take medications, they could go for ablation as a first choice. In the past, we used to say, okay, you had to have a class 1 or a class 3 antiarrhythmic agent before I would offer you, and fail that or not tolerate that before I offer you ablation. But now the guidelines would say you could even offer it as a first-line therapy. And this reflects the data that is coming over the last 10 years that AF ablation is becoming a more upstream treatment. So the earlier you deliver it, the better outcomes patients get with it. Patients with symptomatic persistent atrial fibrillation, and patients particularly who develop heart failure, who have heart failure, these patients tend to do much better when they're in sinus rhythm. There's very strong now randomized controlled trials that show this. AF is a progressive disorder, and the success rates drop significantly when we delay ablation. The problem that we have here in the Middle East is that either patients get referred to us after the first episode of AF, and that's probably too early, or they get referred to us when they're having breakthrough episodes of atrial fibrillation despite being on amiodarone, for example, and that's probably too late. Or if they've been in AF for like 6 months or a year, and again, that's probably too late. So we need to target those ones who have atrial fibrillation for 2-3 hours and then they go back to normal rhythm. That would be the ideal category that would benefit a lot from the ablation. So the success rate is about 80 to 85% in true paroxysmal atrial fibrillation. It's about 60 to 65% in persistent atrial fibrillation, and it's about 50% in long-standing persistent atrial fibrillation. And that's with doing multiple procedures. But the way I tell patients is that if I don't do anything, you will be in AF for the rest of your life and there's nothing we can do about it. If we do an ablation, you have a 50% chance of bringing you back to the normal rhythm. And that's good odds. If you're symptomatic with the atrial fibrillation, it's not great percentages, but if I don't do anything, you will be in AF for the rest of your life. And I always tell patients, you may need more than one procedure for atrial fibrillation. It's just the nature of the beast. It's even Michel Hesseger, who is the father of AF ablation, he has patients that he has to redo procedures on. Complications are tamponade, phrenic nerve injury, CVA or atrial fistulas or PV stenosis, but most of these are very rare, and in general, the risks are less than 1%. So this is a case of with 3D mapping with radiofrequency ablation with burning. So what we do is that we isolate those 4 veins. You can see the veins are now red. So after we've done the ablation, there's no electrical activity there. Red means no voltages and purple means healthy voltages. So you can see we've isolated the veins electrically from the heart. We can do this also with something called cryoballoon. So it's a balloon, we wedge it into the mouth of the vein, inject some contrast to make sure that there's nothing leaking, and then we freeze it to about -40, -50 degrees. So that's doing it with freezing technology. Sometimes we need to do more work, not just isolating the veins. So we can do lines in the roof, we can do lines in the floor of the atrium, so isolate the back wall. We can do anterior lines, for example. So all of this would segment the atrium. Basically, it's like doing a surgical maze procedure, but doing it with catheter ablation, for example. So who is the ideal patient for AF ablation? Young symptomatic patient, paroxysmal atrial fibrillation, small left atrium, ideally less than 4 centimeters. Patients who develop heart failure when they go into AF. This is a very important category to treat. BMI less than 30 ideally. I know it's the difficult one to achieve in this country. And treated risk factors. So if they have hypertension, treat it. If they have obstructive sleep apnea, treat it because it improves the success rate of the ablation procedure. I'm finally going to talk about PVC and VT ablation. So for PVC ablation, the indication would be frequent symptomatic PVCs. So 2% PVC burden is not something I can do an ablation on, but it needs to be at least above 5% kind of morphologies that I can work with. And ideally, if it needs to be more than 10%, because I need to see enough of them during the case to be able to locate where they're coming from. And the ones which are leading to impaired ejection fraction. So there's something called PVC-induced cardiomyopathy. So if people have PVCs more than 15-20%, they're likely or possibly could develop heart failure because of that. And if you get rid of the PVCs, their ejection fraction goes back to normal. So that's an important category to treat. Success rate, it depends on where they're coming from. So RVOT or true RVOT, you have 95% success rate. If they're coming from the LVOT or the aortic cusp, it's about 90%. But you get some locations like the LV papillary muscles, because the motion in that area is very severe. You don't get good stability. The success rate goes down to about 70%. Complications are rare, like tamponade or damage to the coronary arteries or the valves. But these are rare things, I would say. So this is an example of a PVC. Again, we do a map. This is the RVOT. We're looking from the side here. It's a kind of a septal location. So we end up doing few lesions of ablation to cover that area, and then the PVCs would disappear after that. For VT ablation, recurrent normal heart VT, like RVOT VT or fascicular VT, despite medical treatment, or the patient cannot tolerate medical treatment, or recurrent ischemic VTs leading to shocks from the ICD. The success rate, we're talking about 90-95% for normal heart VTs, about 70-80% with ischemic VTs, and about 70% or so for non-ischemic VTs, because these tend to be coming from deep inside the muscle, so our energy doesn't get to that area very easily. Complications, the usual, tamponade, stroke, heart failure, MI, but these are very rare things. So what do we need from you when you refer a patient for ablation? If you can send us at least your clinic note or a referral letter, it'll be very useful. It's useful for me to see what you were thinking, or what the things that you saw, or what you discussed with the patient. Even if you send me a WhatsApp message, that's actually very useful, because I know, I remember what you said in that case. A detailed history of his medications or what they've tried before, that's very useful. If you have an ECG or a Holter or something showing the tachycardia that you want me to ablate, please send it to me, because first of all, I need to satisfy myself that, okay, I am doing the ablation for the right reason. And the second thing is that the insurance company will want to see the ECG for them to give us the approval. If you have done an echo, send me the report. It will save us from having to repeat the echo again. And it's very useful if you have the initial discussion with the patient, okay? So the patients like it when they get something called confirmation bias, okay? So they get biased towards a treatment when they hear 2 or 3 people telling them the same thing. So they go to the first doctor, the second doctor. If the third doctor tells them it, they will accept it. So if you start that discussion with them, tell them, okay, don't tell them that you're definitely going for an ablation. Tell them, I'll send you to discuss it. It's a good treatment. Go and talk to the doctor and see the percentages. But you start that discussion with them. So in summary, ablation procedures offer an attractive alternative to medications. They often have high success rate and low complication rates, and the technology is continuing to improve, which will increase the safety and success rate of these procedures. Your patients, if they want to, you can go our website, theheart.ae. They've explained a lot about ablation procedures, both in English and in Arabic, and about all kinds of heart rhythm procedures, about the conditions themselves. And always remember, ablation is salvation. Thank you very much.
Thank you very much, Dr. Mu'taz, for your excellent presentation. And before we take any questions from the audience, I would like just to ask you, now that you mentioned how important is ablation for our patients, and that we should refer them as early as possible to get the best results. I want to ask about two type of patients that we face a lot. First of them is the SVT patients. And your message would be also for our colleagues working in the ER, giving the patient adenosine, aborting the attack, and then sending them home. The question is, for every patient that gets SVT, as you just mentioned, who needed to go to the hospital, that means this SVT has been there at least half an hour, 1 hour, affecting his life, and he wanted to go to the ER, he had to, and it was aborted by adenosine. For this patient, would you recommend us to refer him directly for ablation, or should we try antiarrhythmic medication with him? And what are the peri-procedural medical treatment, anticoagulation, antiplatelets, antiarrhythmic? That's my first question. Thank you.
For the first question, for SVT patients, I think most of the times, the first or second time it happens, patients end up going to the hospital because they don't know what they're dealing with, they're frightened about it. Later on, I have a lot of patients who've learned how to terminate them. They're happy to terminate it at home with holding their breath or drinking cold water. I'm not necessarily too fussed about it. They don't necessarily have to go every time it happens. Obviously, if it continues and it doesn't terminate, they'll probably have to go to the hospital to get it terminated. I had a patient who's a paramedic that we've just ablated a couple of weeks back. She knows that she has SVT. She recorded it on the monitor in her ambulance, but she'd never been to a hospital with them. She had atypical AV nRT, we ablated it. But she knew exactly how to terminate it. She would say, okay, I get them, I can terminate it, I can stop my breathing, and it's fine. And I'm happy with that, but as soon as I need to have the confirmation that they had it. It's slightly more difficult for me to justify taking somebody to the cath lab when I don't know if they truly had an SVT or not. In terms of when to refer it, depends. For sure, if it's happened more than once, I think it's very reasonable to send them for ablation. Patients in the Middle East are very conservative. They don't like procedures. But I always tell them it's likely to happen again. It's likely to happen anywhere. You could be flying, you could be driving, it could happen anywhere. And it's a treatment that has a very, very high success rate with a very, very small risk of complications. So the odds are very good in their favor. So for SVT, we're quite aggressive to say, okay, if you get it more than once, you can send them for the ablation. Some people even would go for it even after the first ablation. In terms of antiplatelets and anticoagulation, for SVT, I tend to give them some heparin during the procedure, but beyond that, I don't give anything. If we ablated the left-sided accessory pathway, we tend to give them aspirin for 1 month after the procedure. For left atrial ablation, like AF ablation and things like that, they will be anticoagulated at least for 3 months, and beyond the 3 months, it will depend on their CHA2DS2-VASc score. So if their CHA2DS2-VASc score is more than 1 or 2, then they'll have to continue on it, at least for the time being, with the common data that we have.
Thank you, Mu'taz. That was really an excellent, I know it was short notice, but short time, but it was really excellent. Covers all of it. So I think and if I was going to have an ablation, I would go to Dr. Mu'taz, because obviously I can't do it myself, right? But in all seriousness, we see patients coming back to the emergency room 10, 11, 12 times getting adenosine. This is unnecessary, right? The success of ablations right now with the modern technologies and the skills we have are really very high. We're talking 99% for typical AV nRT. Very low recurrence rate, very safe. So it really is a class 1 indication to refer and get it done. There is one group of patients I don't think we covered, which are patients with pre-excited AFib. Now, pre-excited AFib is a cause of sudden death, and you have to look at it in a very different mindset. These patients really should not leave the hospital if they have rapid pre-excited AFib. We've seen patients get discharged on amiodarone and whatnot. These patients need to have an inpatient ablation.
Correct.
And I can just make that point very, very clear, because this is one of the things that these patients can die, and antiarrhythmics will not modify this at all. So just to highlight the importance, and as we have now a lot of access to EP and ablation in the private sector, I think this allows a lot better access than you guys had in the past with the difficulties in referring to the bigger tertiary hospitals. So
Another question, Dr. Mu'taz, is regarding.
Can I have question, please? Can I have question? And Dr. Fakir. Yeah. Unless we allowed, or it is for the for you alone. What about the pulsed field ablation, Dr. Mu'taz? I mean.
So pulse field ablation is pulse field ablation currently is available for atrial fibrillation. It's just entered the UAE market. It's gone into the big hospitals in Dubai, and it's coming soon to the big hospitals in Abu Dhabi. So pulse field ablation is non-thermal energy. So the way it works is that you give an electrical impulse at certain amplitude, and what that would do is that we will open holes in the surface of the cells and then we'll close them. And with time, this will cause something called apoptosis, which is programmed cell death. So the advantage with it is that you're not delivering energy to the cells, so you don't cause heating or cooling to the tissue. This is a big advantage, because one of our biggest problems with ablating atrial fibrillation, we always worry about the esophagus on the back wall of the heart. With pulsed field ablation, you can ablate the hell out of the back of the atrium without worrying about the esophagus, because it doesn't cause any change in the energy. So from my point of view, I think safety, it will increase safety of our AF ablations. Success rate, so far all the studies are showing that it's on par with cryoablation and radiofrequency ablation. So I think the success rate is probably unlikely to increase currently with pulsed field ablation, but the safety will probably increase gradually with pulsed field ablation. Particularly that will become more brave in terms of ablating into areas where we were a little bit more afraid about ablating on in previously.
Because they said that the future will be for pulsed ablation. Do you agree about that?
Pulsed field ablation will be there. I don't think radiofrequency or cryo are going to disappear. So you have to remember, every time a new technology comes, everybody will say everything else is going to disappear. Radiofrequency has been there since the 80s. Cryoenergy came in 2010, and they said the same thing. Both of them are still available, okay? And I think each one of them will have advantages and disadvantages to working with. So radiofrequency allows you a pinpoint kind of accuracy when you're doing ablation. So if you're doing a pathway or something, there's no reason why you should go to something. Like you got a 99% success rate in some of these ablations. Why would you want to change it? Do you see what I mean? It gives you a durable lesions. You know the outcomes. You have 40, 50 years of data on them. So you have less incentive, and the catheters are going to be cheaper as well for radiofrequency. So I don't think any of the technologies are going to disappear in the near future. But pulse field ablation is going to become more predominant for AF ablation. And they are developing other catheters that would allow us to give, point-by-point ablation with pulse field as well.
Dr. Mu'taz, Azmi Abdullah Shahab here. So I think that question is important to the patients when you mentioned the technologies, these 3 technologies or 4 technologies we have. I know Rashid Hospital, they were the first to bring this here. But again, patients, I know efficacy is important, but safety is important. If you have something more safer, I think that's what I think Dr. trying to say is that this is the future, because the safety is as important for the patient.
So each technology has its own problem. So pulse field ablation doesn't give you energy, okay? But if you ablate too much, you can cause hemolysis, and some patients end up with renal failure and dialysis because of that. So each technology has its own issues. So at one point, they started using it on the mitral isthmus to cause mitral isthmus block. They end up causing coronary artery spasm. So you have to understand, it's a new technology that we're just learning how to use it. On the other hand, I agree about the point of safety, but let's say for straightforward isolation of the pulmonary veins, I've done about 1,000 AF ablations with cryoballoons. Touch wood, I've never had any issues with them. So like when you have technology where the success rate is high and the safety is very, very good, it becomes a little bit more difficult to make it even better. So it's all theoretical kind of thing. As I said, it would allow us to deliver more energy on the back wall of the heart. So my own way of how I'm going to be using it in the future, if I'm going to be isolating just the 4 veins, I'm happy to use any technology. If I'm going to ablate on the posterior wall, I'll probably do pulse field ablation, because I will be able to deliver more energy with more safety and to the patient. Okay.
Excellent. Thank you. Thank you very much. I'm sure there's going to be a million questions. I'm sure Dr. Mu'taz will also be around there.
Next speaker, we have our dear colleague, Dr. Rami Harb. He's a consultant cardiology at Health Point Hospital. Dr. Romi completed his training in internal medicine and fellowship at the American University of Beirut Medical Center. Then he joined the Heart Hospital, University College London. He specialized in inherited heart disease, and his special interest is treatment of cardiac muscle disease. Thank you, Dr. Romi, for being with us today. And Dr. Romi will be talking about arrhythmogenic right ventricular cardiomyopathy. Thank you, Dr. Romi.
Thank you, Dr. Iman, for the kind introduction. I don't know how to squeeze arrhythmogenic right ARVC in like 15 minutes after Dr. Ahmad has allocated this slot to me, but thanks, Ahmad, for giving me your time. So we'll start. So I have no disclosures. What we're going to discuss here the pathology in this picture. So as we see that the right ventricle is affected by some fibrofatty replacement. If we compare this tissue to this tissue of the left ventricle, and we see that was a problem in the ventricle. What we're talking about as well is the invasion of the normal myocyte by fat tissue and fibrosis. So fibrofatty replacement of the ventricle of the myocardial tissue. Just to review as a baseline, the structure of a cardiac muscle cell is The structure of a cardiac muscle cell is like that. So these are the mitochondria. This is the intercalated disc. That the pathology ARVC is mainly involving desmosomal gene mutations, as we're gonna see. And this is a cross section of an affected of a cardiomyocyte, where there is the nucleus, the mitochondria, and the intercalated discs. So the role of the cardiac desmosome and proposed roles are in supporting the structural stability through cell-to-cell adhesion, regulating transcription of genes, and electrical conduction through gap junctions and by regulating calcium homeostasis. As we're going to see that the ARVC will be involving a genetic mutation in mainly these genes, the genes encoding for these molecules. So ARVC is an inherited disease characterized by fibrofatty myocardial replacement. The prevalence is up to 1 in 5,000 individuals, depending on the different studies. There is male predominance among probants, and usually males presenting with sudden cardiac death and VF are usually younger, with a median age of 23 as compared to sustained monomorphic VT in presentation. Age 23 as compared to 36 as median age for those presenting with sustained monofocal VT. So it is a pathogenic mutation in desmosomal genes mainly, and less commonly in non-desmosomal genes. Genetic testing is important as indicated in identification of a mutation and is a major criterion, as you're going to see in the task force criterion later on, and different criteria. Some unfortunate people will have like digenic, so 2 mutations, and they are at more risk of having ventricular arrhythmias at younger age. We've seen, if we compare the new criteria, which is the latest one, the 2010, as compared to the 1994, that the penetrance among first-degree relatives has increased in terms of frequency as compared to the old criteria. And as I said here, that patients harboring more than one gene are at more risk. It is mainly RV involvement, though it can involve the LV. And we can see that in certain studies, and patient scanned having MRIs, they will have LV involvement, as we're going to see in a bit. Up to 45% of probans will have that, but that may be present before they meet the major task force criteria for imaging criteria. Wall motion alterations, repolarizations, everything will be involved in the task force criteria, as we're going to see in a bit. The identification of biventricular and left dominant involvement led to the change or proposed change of the term of arrhythmogenic cardiomyopathy, not specifying right ventricular only. So the most important thing is the history taking. Usually there are red flags in the history, features of arrhythmogenic syncope, family history of premature sudden cardiac death, or certain features like, for example, palmoplantar keratosis and ARVC in certain, I'll give you an example now. For example, Nexus disease, this is an example, which is the people of certain island, not far away from us. So they present with palmoplantar keratosis, and they have like curly hair. Once they are prone to have lots of arrhythmias and sudden cardiac death at young age. Their ECGs do show signs of late excitation, which is the epsilon wave that we're going to see in a bit. And usually they're having a genetic mutation at plakoglobin, and which causes the deletion of the GT from the sequence in the plakoglobin. So this is a whole set of genes involved. Mainly we're going to focus on the 3 or 4, plakophilin, desmoglein, desmoplakin, and desmocolin, with the plakoglobin, the example that we've seen earlier on. The diagnosis then mainly is focused on ECG diagnosis. And in ECG, we do focus on the famous epsilon wave that is usually present after the QRS. It's a late excitation wave. In addition to that, to the ECG comes the signal average ECG. The signal average ECG can detect very low amplitude signals in the terminal QRS. So at the end of the QRS, there are certain signals that code for late excitation. So what we should focus at in these patients are the QRS mutation, low amplitude signal duration, and root mean square voltage. So they usually, the study will be like that. I mean, it's dividing the QRS complex into this late excitation. There are certain criteria in terms of QRS duration, the amplitude of the late excitation, and the duration of the late excitation. So there are certain norms. For example, in patients with epsilon wave, like in this example, where there's an epsilon wave, a signal average ECG show that all of these parameters are affected. If we can see correlate here from the data on this specific patient, classifying this patient as having a minor criteria for ARVC. Signal average ECG is minor criteria in the task force. So that's what we see usually in MRI, as we're going to see in the next video. So this is, sorry. Fine. So this is LA, LV, RA, RV. So this is the RV free wall. It is, we can see the difference between this pattern in here and the normal, relatively compact septal structure. So it's here, there is fibrofatty replacement. Some of these white dots may represent some pockets of fibrofatty replacement in what should be a healthy tissue. So talking about the RV disease as well, LV disease may be present with late signal, with signal average ECG abnormalities, again involving the left ventricle, which is here the lateral, basal lateral, or anterolateral, and basal inferior and lateral wall with subepicardial involvement as well. So the diagnosis usually, before going to the next slide, which is really shocking because it's very crowded, the task force, what we usually focus at are two major or one major and two minor criteria, or four minor, in order to diagnose, to have a definite diagnosis of ARVC, whereas we may have a borderline diagnosis if having one major and one minor, or three minor, and possible diagnosis for the other cases. So what we're going to focus in here, we're going to focus only on the majors in the revised task force. This is 1994, this is 2010. So the major criteria in the diagnosis. So once we have, we should understand how we should apply this task force. If we're making diagnosis according to echo or according to MRI. So the MRI, there are, in addition to the RV akinesis, you should have one of these. In addition to the RV akinesis and echo, you should have one of these as well. And the minor criteria is slightly different deflection from the major. Whereas as well we have a major criteria for tissue characterization by biopsy, which is having in more than one biopsy from the right side of the heart, from the right ventricle, having less than 60% residual myocytes. Whereas in other minor criteria, the percentage of normal residual myocytes is more than 75% in more than one biopsy. The third characteristic is the repolarization abnormalities, mainly T-wave inversions anteriorly in people with an age group, with subjects with an age group of more than 14 years of age, and otherwise they will be classified as minor criteria if they are only in V1 to V2 or in V4, V5, V6. Mainly the major is V1, V2, V3 T-wave inversions if more than 14 years of age and not having right bundle branch block. The second set is the epsilon wave, which remains as a major criteria as well in the depolarization, whereas the late signal average ECG is a minor criteria, as I explained before. The arrhythmia, non-sustained VT with superior axis is coming from RVOT down. So that's a major criteria, whereas the other non-sustained VT coming from inferior and other sides is considered, or an unknown axis is considered minor criteria, or people who having more than 500 is considered minor criteria. So we have to count points. In fact, two majors or one major and two minors, this is a definite diagnosis. And here we're talking about the family history of people involved. So this is again some simplification of the criteria. In 2020, Corrado et al., 2021, sorry, Corrado et al. Listed the 2020 international criteria, tried to summarize what I mentioned before. However, what has changed is the ventricular ectopics more than 500. It's listed as major in here, whereas it's listed as minor in the 2010. What we're focusing at, I think, in our practice is mainly the 2010 criteria. It's at least everyone is referring to this task force. Here as well, that I'll skip through these. These are simplification as well of the task force criteria with people just depending on the diagnosis by just the ECG and arrhythmia criterion before referring for any of these investigation tools. So the most important thing is the risk stratification. We should try to classify patients that are at risk of cardiac arrest. We should, as well in our history, check about syncope, VT with hemodynamic compromise from the investigation, the signal average ECG, extensive RV involvement, and the LV involvement, as I mentioned before. So questions, how commonly does sudden cardiac death occur in ARVC? So we may have people with sustained monomorphic VT, whereas they are not at risk. It depends on the cycle length of the VT, so they are not at risk of sudden cardiac death as other people, and who will be benefiting from ICD implantation. So risk stratification, quickly, I'll go through this quickly. So in people not implanted with ICD, I mean, who do not have ICD implanted, the cardiac arrest occurs only in 6.1% after follow-up for 8 to 11 years, whereas 23% experience sustained monomorphic ventricular tachycardia. So the sustained monomorphic ventricular tachycardia is not as malignant to them, whereas 6.1 will have malignant arrhythmia. Whether this is acutely life-threatening depending on the cycle length and cardiac function as well, as I mentioned before. Among those who have ICD implanted, 23 to 48% will experience ICD shocks or ICD intervention during follow-up period of less than 5 years. However, only 16 to 19 of these cases are triggered by significant arrhythmia. It means if we calculate the 16 or 19% from the 23%, it's approximately equal to 6.1% from those who did not have ICD implantation. 3 out of 4 have appropriate ICD shocks. As well, as I said, not all of the ICD shocks are due to a life-threatening arrhythmia. People having well-tolerated VT are at lower risk of sudden cardiac death, and the implantation of ICD is not clear with them, but however, we go and implant in order, there is no data to tell us not to implant on those people. Sudden death in the young, we see that ARVC counts for like 13% of the sudden cardiac death. It's a study from 2001. The percentage has not changed among the recent studies. And here, I'll skip through this one. I'll go directly to the treatment. So whom shall benefit from ICD? Those people who have arrhythmic syncope would benefit from ICD implantation. People that have biventricular involvement, mainly RV fraction change of less than 17% or RV ejection fraction less than 35. And those who have RV involvement and LV involvement with an LVF less than 35%, will be dealing with them as if we're dealing with dilated cardiomyopathy. Supporting data are lacking, however, ICD should be considered in symptomatic ARVC patients with moderate, less than 40, or LV dysfunction less than 45, who have either non-sustained VT or have inducible monomorphic VT by electrophysiology, during electrophysiology study. I'll skip the first one because I talked about it. The subcutaneous ICDs reduced the trauma and in these people, especially if they're young, and help those people by, overcome the events that they're having. Additional treatment to suppress the ventricular arrhythmias is helpful. However, it's not supported by lots of studies, and especially beta blockers. Mainly limited data suggests potential benefit of atenolol over bisoprolol. I will leave it to our EP colleagues to comment on this. And antiarrhythmic therapy may have efficacy, although sotalol was effective. It did not suppress clinically relevant arrhythmias. Amiodarone or class 1 drugs were associated with lower incidence of VT recurrence. And as Dr. Mu'taz has mentioned, that catheter ablation is usually successful in this cohort of patients, especially has been associated with promising VT-free survival. Prophylactic measures, restriction from high-intensity exercise regarded as a preventive tool. Whether sports restriction is beneficial is not known. However, that will decrease the sympathetic stimulation, which is a real trigger for VT in this cohort of patients, and which may lead to sudden cardiac death. This is a summary of the recommendations that I said. The class 1 in the ESC guidelines, patients suspected with ARVC, they should have a CMR. Genetic counseling is required as class 1 indication, and avoidance of high-intensity exercise due to the sympathetic stimulation are class 1 indications. Class 1 indication as well, ICD implantation is recommended in ICD with hemodynamically non-tolerated VT. Those with SMVT, it's only class 2A. ARVC and non-sustained VAs, beta blocker therapy is recommended. Again, however, that's not supported by lots of studies. And the first degree relatives of patients with ARVC, only ECG, that's how to screen relatives. ECG, we can start by an ECG and echocardiogram in competent hands, and we can mostly either rule out or at least know the second step whether to send the patient for genetic analysis. On conclusion, ARVC is a genetically complex disease, as we have seen and as we know, characterized by marked interfamilial phenotype diversity. The diagnosis relies on structural, functional, and EP abnormalities. Technical advances, MRI to the echocardiography, and 4D CT as well is offering lots of help in the diagnosis. The task force criteria and the adjustments to the task force criteria, mainly the 2010, remains pivotal in making the diagnosis. The effect of revised criteria is to increase the sensitivity and avoid false diagnostic or false tagging of patients as ARVC, whereas they will not be having ARVC. ECG criteria, repolarization, depolarization, as I mentioned, and left bundle with inferior axis, typical of RVOT, tract tachycardia, ventricular ectopy, and the awareness is growing now about the left variant ARVC, and would reckon that most of the criteria will be involving VT with right bundle branch block morphology as coming from the left ventricle. That is discussed to be in different studies, and the genetic diagnosis is particularly useful to confirm the diagnosis and screen relatives at risk after, of course, ECG and echocardiography. That's it. Thank you.
Thank you very much, Dr. Rami, for your excellent presentation. Any questions from the audience?
Excellent talk and great journey through this. I think it's very complex. And sometimes, or most of the time actually, in this area, we discover them when they have a sudden cardiac death. And I'm really interested in the sporadic cases, which is, we don't have genetic behind it, and ECG very normal. So puzzle, I want I think the electrophysiologist here as well.
Yes.
How can we help? And every day, we hear in the news. I mean, news likes, this إثارة, just show us in the newspaper somebody, playing and sudden death, and then discovered retrospectively maybe
This is minor criteria. So this is minor criteria. If it is maybe, it's minor criteria unless there is an autopsy verifying that this is ARVC, to classify it as major criteria for those people, especially if they are less than 35 and they collapse with a probable diagnosis. So there will be as minor criteria in what I've mentioned, those two ugly pictures, the big table. So it will be as classified as minor. You have to have another minor and a major to classify it, or 4 minors, to classify it as ARVC.
Thank you, Dr. Rami. Any other question from the audience? Thank you very much, Dr.
Thanks.
Rami.
Thank you. Thanks.